Welcome back to Thriving Beyond the Stethoscope. I'm Natalie Tyler, triple board certified nurse practitioner and owner of ThriveWell Medical Center. Today we have Christelle here, who is an amazing RN or registered nurse, and she's going to talk to us a little bit. Christelle, if you want to introduce yourself.
Hello, my name is Christelle Media Robinson. I'm an RN with over 10 years of experience, which most of them have been in oncology, and never thought I would be an oncology nurse when I started nursing. I always had, when we addressed the oncology topic in school, it was like, I'll never be an oncology nurse, and look at me now.
That's exactly what I thought too. They went over it for a couple of weeks, and I was like, oh, well, guess that's it.
Yeah.
I love it. Well, okay, so tell us, what does a typical day in the infusion room, especially oncology infusion room, look like?
So a typical day is going to be patients are seeing the doctors and are going to go and move on to. Uh, so first, a patient comes in, gets registered, gets their labs done, sees the patients. The doctor reviews any anything that is happening with the patient. It could be any side effects that, from previous treatment. It could be, it's the labs. We'll review the labs. And then the patient comes to us to do the treatment if patient is deemed stable to receive the treatment that is due on that day. Um, at times, the patient comes to us before seeing the doctor. So at those times, we have to communicate. It's important to have that open communication with the doctor if we are to be starting a treatment before the patient sees the doctor. And we are to report all the lab results and signs and symptoms that the patient is having or has been having since their last treatment or just recently in the past day or in the past few hours. And so when the patient starts with us, we establish either IV access through peripheral IV or accessing their port are implanted in either side of the chest. So that takes a little bit of time, and I do believe that is something that providers tend to forget at times, that all this care before the start of an infusion takes some time. It's not just jumping right there and then, and starting with the infusion that was ordered. And a lot of times it's forgotten, the background, before, or the few steps before getting onto the infusion itself. Um, we start with pre-medications, observation, making sure that the patient is ready to receive either immunotherapy, chemotherapy, or basic infusion of either electro, electrolytes or iron even. And so pre-medications, and then here goes the time for the the main treatment: immunotherapy, chemotherapy, biotherapy, or iron infusion. And depending on the treatment, then we set up for specific time for that infusion. And everybody is on guard, because it does not matter which treatment or which cycle the patient is into. The patient can react to the medication at any point. And we have to be aware and make our colleagues aware of what cycle the patient is in or at, depending on the medication, because some medications you will not have the reaction on the first cycle, but rather on cycle 6, 7, or 8. And the patient could have had some immunotherapy for many weeks and have gone with any no trouble whatsoever. And then all of a sudden, the body decides, I have enough, and I'm going to have a reaction right there. And reactions can go from uh, a simple little scratch in the throat or a little bit of itching in the skin to a full blown difficulty breathing, redness in the face, not being able to breathe, um, chest pain, back pain, and we have to jump in and prepare for that emergency because now we are on, emergent reaction mode. And so some nurses calling the providers, reminding them of the treatment, what the pre-medications the patient has received. Um, and in the meantime, we have been taking vital signs. We have stopped the treatment, of course, as soon as anything is happening, patient starts to complain, and we're running IV fluids right away. Difficulty breathing, we oxygen saturation level. We decide, right there and then if the patient is going to require oxygen. And in some cases, we have to call 911. And that's, where it comes to. If we are unable to treat that reaction in a timely fashion, we have that the recourse to calling 911 and the paramedics, and they are coming rather quickly. And thankfully, we have that recourse. I have to say that we have a great team of nurses and physicians and nurse practitioners, and they are on it right away. If we need them at chairside, we overhead page them, and they are here at chairside and assessing with us and the situation and seeing if and what other emergent medication we can administer the patient in the time being. And we are, all eyes on the patient and
Mhm.
connecting with family, trying to get the family aware of what is happening and trying to reassure. So those reactions, can be traumatic for the patient and the family as well.
Yes.
So trying to keep the patient as calm as possible is the main goal, because the more nervous, the more agitated the patient is going to be, the more difficult reactions are to be treated and handled. So it's not always easy, but we're professionals and we're able to thrive through it all. And so that is to say, we don't have reactions every day.
Right.
And thank goodness. And but it's it does happen, and that's it could be a typical day. It could be a smooth going through all those treatments without any issues, and some other days we would have a few reactions during the day, and it depends on the treatment, the cycle, and the medical history of the patient as well.
Yeah, I always
So
remember you especially being very good about communicating. So whenever we got the call as the providers and there's an issue going on, I remember us always making a priority to come back there. But it's really good and I really like how well you communicate what's going on. I'm not getting any extra information. I'm just getting the facts, and then we're getting what medications we've done, even recommendations from you guys on what medications we should probably do again, especially with our different antihistamines or steroids for our reaction purposes. And I got to tell you, I remember most of our reactions kept coming from iron for a while there. Iron, you think it's just so
And
simple.
and unfortunately, yes, it is. Iron is a very reactive medication, and people just think, hey, it's just iron. How much, how bad can it be? And it can develop like this with, starting to have a scratchy throat and upper back itching, and before you know it, it's, full blown, reaction. And oh, you can never keep, let your guards down, unfortunately. Um, we we have come actually with some protocols, and whatever, the patient's age and the patient's medical history. Now we have the ability to put some we have standing orders
Hmm.
for pre-medications, and which we didn't have in the past. So um, we have this new standing order for depending on the history, and that's it is good because we don't have to go back and forth with the provider and trying to not argue, but prove the fact that a patient is actually does need to have the pre-medication, so we will decrease, the chances of having a reaction. And maybe the patient will not need these pre-medications before each treatment,
Hmm.
but at least the first treatment, trying to prevent it, is goes a long way to try to even calm the patient, or put the patient at ease with that so-called easy treatment.
Yeah.
It's an easy infusion treatment. It's an easy iron treatment. And unfortunately, it's not as easy as it sounds, to just be like, we'll just order you some iron. Everything's gonna be okay.
Yeah, I mean, they get
And
great results from it, but you do have to be diligent and aware. And so
yeah.
you kind of touched on some of the signs and symptoms that we see when people are having reactions. What would you consider the more subtle type of signs or symptoms that you've seen with reactions?
So a little redness in the face, little itching. Oh, I'm starting to feel, some my
Hmm.
face, being hot, or feeling my chest being hot,
Yeah,
and be like, oh, okay, this is
this is
it.
it. So then,
And
how do you triage normal, something normal side effects versus possible urgent escalation?
so if I'm on the phone with you, so let me try to say, I don't see the patient, and a patient is telling me, you know what, I'm having a little bit of, nausea. I haven't been vomiting or anything like this. I'll be like, those are typical, side effects of your chemotherapeutic treatment or
Hmm.
immunotherapy treatment. Um, so often we leave the patient, or the patient would leave, after the first treatment, or with the first treatment, with a prescription of antiemetic. So hopefully the patient has started the night of that first treatment taking these oral antiemetic, anti-nausea medication.
Hmm.
And as a prophylactic measure, this is what I always recommend my patients. Do not wait until you have a full force, nausea, and you feel like you're about to start vomiting.
Yeah.
Just act prophylactically and start taking your Zofran or Donsitron, whatever,
Any of them,
antiemetic
right? The
has been.
promethazine, any of them.
Exactly. So that is always my recommendation to the patient. Yeah, before you go to bed, take your antiemetic medication. You better off starting to take it, now, acting
Mm-hmm.
prophylactically than having to try play catch up. Once it's started, it's difficult to actually manage.
I agree.
So those are
Actually, I'm so sorry to cut you off, but I
no,
am
no,
thinking very specifically because you're right. Once people get started with nausea, then it becomes cyclic, whether they're not eating enough and that makes them more sick, or even just the psychological component that comes with nausea. So I had a patient in the past who we had treated with several different types of antiemetics, and we even switched over to some of our psychotherapy type drugs, which chemotherapy or oncology likes to use those for antiemetic purposes, and she was still struggling. So it ended up being like a psychosocial or a psychological issue where she was fearful of being sick, and it created anxiety, and then that anxiety then created more nausea, which Zofran's not going to help with the anxiety driven nausea. So I agree,
correct.
it's important to keep eating and make sure you're prophylactic. So go ahead.
Yes, definitely. And I can't stress that enough, and try to even push it. With some providers are a little bit reluctant to go onto those uh, you know, um, other modes of remedies. And but yeah, Ativan, is being used as, an antiemetic. And I've seen it, when I was in New Jersey, and trying to push it a little bit more here, um, at the beginning of the treatment rather than when it's too late and the patient is already struggling and already has seen that great weight loss. And because they're afraid then, to eat, because they're afraid they will be vomiting, unfortunately. Yes.
I agree.
And uh, unfortunately, I feel I see that reluctance a little bit more, being here in Florida, more so about this type of treatment, um, than when I was, up in New Jersey.
That's very
Yeah.
interesting. In fact, I
Hmm.
remember psychiatry, there's such a gap with psychiatry and oncology, at
Yes.
least where we are in Southwest Florida, which is why I went to become a psychiatric nurse practitioner, is to fill that gap. Because there's definitely a lot of other things that we can do for these patients. So, like when they come in and they are mentally, you know, anxious or depressed, especially because of their diagnosis and they're worried about treatment, our mind likes to play tricks even on our body, and it can trick us into the nausea, for example, or is the treatment going to work or not, and that can play an effect into their recovery. And so with that in mind, do you and have you ever just tried to identify those kind of patients, and then what kind of recourse have you tried for them, or maybe you haven't? It's okay, I was just curious.
So I have, and I have one specifically in mind, and it's been extremely, extremely difficult to treat his nausea. And I have tried actually essential oils,
Yes.
and essential oils work
Yeah.
wonders. And natural remedies, teas, and people would say, "Hey, just drink a ginger ale." Well,
Hmm.
actually, the ginger ale itself is not, so much the great remedy, but the ginger itself is what you want to aim for.
Yes.
And so I'm always very cautious when I try to recommend these type of natural remedies,
Hmm.
because um, I want to explain that to the patient very, very carefully, because their immune system can be completely depleted.
Yeah.
And trying to introduce uh, a new new food, a
Yeah.
new remedy, natural remedy to their not compromised system and to introduce it to their diet can be complicated. So I try to explain it to them very, very carefully because you can take the root, a ginger root, clean it very, very carefully, and boil it and make a ginger tea. Just that root itself, adding the peel of an orange or lemon, and making your own natural ginger tea. And I have patients who swear by the ginger tea, the ginger remedies that I have been telling them to try to do for themselves, and said that's the only thing that has been working for them.
I love it. I love natural and holistic and not just all pills, but pills have their place too, but I love it. We
Yes,
got to talk more
yes.
about that later. Different
We
remedies to
do,
help.
we do. And something that I would love to see being used a little bit more is all those oils, essential oils that
Hmm.
could be like lavender is calming, and by calming the patient can actually you know, help with the nausea because releasing that anxiety, it's
Yes,
all beyond just treating the nausea. It's trying to treat the body as a whole,
it is.
and it's not just oh you're nauseous. I'm going to give you this medication. No, you get to see the whole picture,
Yes.
and a lot of times that's this is what people forget, and to just and so to try to go a little bit further into we we're not just oncology nurses. We are nurses first and foremost,
Right.
so we can deal with heart cardiac issues.
Hmm.
We can deal with emotional issues, psychological issues. We can deal with sexual health issues,
Hmm.
which is another thing that I would love for the providers to address with their patients a little bit more.
Yes, I was going to ask you too. What do you think the nurse practitioners and doctors in oncology should educate more on, or what, in your experience, what do you feel is lacking? So I feel like you're going that way. So go ahead.
So I feel like we just skipped a little bit,
It's okay.
but it's I had started developed in New Jersey sexual health committee for with patient going through chemotherapeutic treatment.
I love that. Why is this the first time I've heard this? That's great. We need that. We need to link up, collaborate.
Yes.
Go ahead.
And with the simple fact that when you receive a patient for the first time, it is important to make sure that everything has been offered for that patient, um, not just in regards to sexual health, but reproductive health as well,
Yes.
and for both men and women.
Yes.
And I feel like the sexual health component is swept to the side, and whereas it is very important to address not just in the reproduction aspect of it, but also into the protective aspect of it, because our patients that we are treating want to come back and want to try to live as normal as possible. They are, they have within themselves hazardous material, hazardous substance that could be transmitted to their partner.
Hmm.
And very often I see it, and I realize that our patients have not gotten that education. How do we protect our partners when we want to remain as normal and have um, as normal of a sexual health as possible, as sexual life as possible,
Yeah,
uh, regardless of the treatment we're going through? And so it is important to address this with, both the patient and the partner present, for both of them to understand, what it entails. And I, I'm not going to say I love to address the issue,
sure.
but I feel like it is important, and I don't see a barrier to me. I feel like it's I have an um, I easy disposition, I should say, to be able to address this subject with the patient. Is it? And we've addressed this. Some nurses just do not feel comfortable addressing it with the patients.
Sure. Whether it's a female nurse to a male patient or vice versa, because I've had plenty of talks about prostate cancer, prostate health, erectile
Mhm.
dysfunction, and everything else in the room with the patient. And I find that it's best to get over your discomforts to be able to tell them objectively what's going on, and then they feel more comfortable. So I know most
Yes.
men feel more comfortable with and talking to me as a young woman in the room and discussing their sexual health, but I think they appreciate, like you're saying, that directness, the education, and then just you even asking them and potentially offering them an alternative option to be able to continue to have that healthy sexual relationship, and then just also growing your emotional
Yeah.
relationship too. So it's important.
Yes, because these patients are going to be on treatments for months and
Hmm.
sometimes years. And it doesn't mean that the intimacy, needs to stop altogether. But educating them on how to be cautious in that sense is important.
Absolutely. And you talked even about like reproductive health. So even our women of childbearing age, if they're going through treatment and we need to talk to them about freezing their eggs or, potential consequences of going through treatment, if that's going to impact their fertility. I've had a couple of oncologists in Naples. They referred to a GYN specialist that deals with fertility issues with related to chemo and can guide them. So I thought
Mhm.
that was very proactive of the two MDs that I was with. So I can appreciate
It's
that.
good.
Yeah.
Yes, yes. And I see that as well. Every time I have a gentleman who is undergoing treatment for testicular cancer, I always address, the harvesting, or um, the freezing of this, sperm, and asking them, have you, gone through this, and has it been done? Because if you want, to have children, this is something that needs to be done prior to the beginning of this treatment.
Yeah, and I bet
So
a lot of people probably aren't thinking about that in the moment. I mean, some
no.
some patients did, like couples that came in, young couples, that was one of their first questions that they would ask me. But you're right. Most of
Hmm.
them don't. They're thinking about now, only now, and then when they get to that
Yes,
future, like, oh crap, I should have had that conversation. So
yes,
I can
yes.
appreciate that. We could do a whole segment on sexual health and oncology
Yes,
and just
yes.
educating people. Um, to switch gears just a little bit, because I know a lot of people out there, especially with nurses and even nurse practitioners, we worry about documenting and legal like liability with documenting. So, have you developed or thought about any documentation habits that kind of protects nurses or protects yourself when documenting?
So it is important to document everything, and it goes from any little signs, symptoms that the patient is sharing with you, it
Hmm.
is important to document it. And it is important to document if a patient is refusing to have the vital signs taken during the rate increase of a medication. It is important to document as well the state of mind of a patient or the way a patient is behaving on any given day during a treatment, how the patient is addressing you, and because unfortunately, um, in this time and day, you see trials, prosecutions happening right and left.
Yes.
And 20 years from now, you are not going to remember an encounter that you had yesterday. And that documentation is going to be extremely important to put a whole picture on what happened that day.
I couldn't agree more. I always try to balance between too much words and just enough because they always teach you to do the minimum so that, whatever, if you have issues. But I'm kind
Mhm.
of the same page. I like painting the big picture so we understand what happened. And
Yes,
then, especially if the patient chooses to refuse that, that's completely their choice. They're
yes,
educated on potential outcomes. And then, as long as that's documented, that'll protect
yes,
you and hopefully it can protect the patient because then they'll understand how serious XYZ is that we're trying to do. So,
exactly, exactly.
so with that kind of comes more back into that psycho or psychological component that comes with oncology. Have you had experience with somebody having a panic attack in your infusion chair? And how did you help it or help them? Or maybe even if they just dreaded their infusion, how did you help them?
So I have had some patients going through reaction and the anxiety of the reaction itself, making it more uh, a little bit more difficult to treat.
Hmm.
Trying to take the patient into a normal, taking the patient back into a normal breathing pattern is the most important thing, first and foremost.
Yeah.
Once the breathing is under control, we are able to try to get the patient to take a deep breath. Take a deep breath in from your nose. So being able to do it, demonstrate, and have that return demonstration, so to speak,
Yeah.
from the patient. You're not doing it well. If the patient is not doing, no, breathe in from your nose, out from your mouth, slowly.
Yeah.
And that, you know, is already 50, 60% of the work.
Yeah.
And it brings down their anxiety level, much more. Telling them what is happening,
Hmm.
telling them what is going on, the medications we are going to administer them to make them feel better. Right away, it's have you have to communicate with the patient. You cannot
Yes.
start doing things without telling them,
Yes.
because more and more anxiety will start building up.
I love how you related
So,
that because I find that even in the office, for example, I have a lot of patients complain about other medical practices when they come in, people just kind of bark orders at them, right? Or just say, hey, we're doing this, this, and this, and we'll see you later. Or just don't ask questions, they don't explain thorough. And I think if people just take that extra few seconds to really just explain why you're doing what you're doing, you're going to get more compliance out of people. You're going to get them to
definitely.
understand. Yeah, I love it. I love everything you do, but you know that already.
I don't
So,
know if you would love everything, but
well, okay, okay, granted. How do you think nurse practitioners can better support infusion nurses? And you can, relate it if you want to just in general, like every day. I mean, it could be related to psychological support or medication support, whatever you think is like top few of your lists? How can nurse practitioners help support you guys?
I do and believe that nurse practitioners are always, maybe I shouldn't say always, there is going to be a few exceptions,
Of
but
course.
open they're open to helping us because a lot of the nurse practitioners have been in the infusion room. They have been in our shoes,
Sure.
and they know how it is to be treating the patient. My for for the very few of them to not forget that they have been in our shoes and to remember what it was like and not to brush us off and to be like, we're all together to be treating this patient. We are next to this patient
Yeah.
most of the treatment. You putting the orders in. If there is a reaction, you ordering new treatment to be added. But we are there 90% of the time.
Yep.
We hear the patient, we listen to the patient, we see the patient, we know the patient. And so that back and forth, that open communication, and give us some credit.
Absolutely. Because I mean, half of us, I'm sure, went from nursing to nurse practitioner because we felt like we weren't heard and we had to be able to help patients better. So I can
Yes.
definitely see how some can forget their roots. I feel like when I was working with you in particular and then other people, I felt like maybe I overdid it because I was like, oh, how can I help? Where can I go? Like, I even was like, oh, I'll start an IV. Sure, let me help. But my place was in the room, seeing patients, getting them in and out. But yeah, I always have to balance making sure that I'm not annoying or feel like I'm, like micromanaging, even though I'm just like, how can I help?
And it is not, because, we love, I personally love, having that help and, having that extra education. I I welcome all that knowledge,
Sure.
that extra knowledge that you have acquired and that you're willing to share with us, to just educate us, give it to us. We're ready and we should be ready. We
Yeah.
shouldn't be, with our blinders and be like, I'm just a nurse. No, you are a nurse.
Yeah.
Your education is constant, it's continuous. Bring it in.
Yes. I feel like in
And
oncology, we have to be that way, especially because of the ever changing guidelines, medications, side effects, profiles, everything.
definitely,
Yeah, especially you
definitely.
guys being front lines to giving the infusions. I mean, you really have to be up to date to know what side effects am I looking for with this medicine? Were they supposed to take a pre-med an hour before they came into the clinic? So you guys definitely have a stressful job. There's definitely a lot more
Yeah.
to it than just let me stick an IV and you give your meds and send you home. You guys do a lot.
So, and on that note, what, I would love to see a little bit more is for the providers to be a little bit more cautious, when a treatment is being started.
Hmm.
Make sure that, all the tests, the preliminary tests have
Hmm.
been performed prior to that first treatment. And it could be, an eye exam that is required
Right. Yes.
with an optometrist or ophthalmologist.
Yeah.
And it is important to have a baseline because this is a medication that is going to be affecting your eyesight, potentially affect your eyesight.
Yes.
And it's always, mind blowing, to see that the patient hasn't been prepared in that sense.
Yes.
or the prophylactic um, medications that they should have been taken at home prior to coming, into the treatment room before having that treatment. Oh no, that wasn't, ordered.
Yeah.
What do you mean?
Yeah,
That
what do
was
you
not
mean?
ordered.
It's part of the treatment plan.
Yes.
That used to be a
And
difficult part for me, like trying to look through all the treatment plans and to make sure, because I was very anal retentive and OCD. It's just like, did I miss anything? And I just had to keep going back through it and make sure I ordered everything. So I get it.
yes. And the thing is, it's not just for us, it's for the patient and patient satisfaction as well. We see these days, healthcare is based on, 90% of it in patient satisfaction. It's
Yeah.
like, oh, you are being rated because of your patient satisfaction.
Yeah.
You're getting, your rate increased because we are doing good because of patient satisfaction. So if all these things are not put in place, if the patient has to be waiting, or his or her treatment has to be canceled because something wasn't done that should have been done,
Yeah.
because they understand when you tell them, have you had your eye exam? Oh no, should have had that eye exam.
Yes.
Um, yeah, we can't do that treatment today without that baseline, unfortunately. Why wasn't it done? Why wasn't I told? So those are going to be unsatisfied patients,
Well, yeah, and
unfortunately.
also delaying their treatment, delaying their
Yeah.
care, and then potentially, depending
Yes.
on what they're on, that can be disastrous or it could be okay, but it's still very inconvenient. And given me being out in Immokalee now with my clinic, I know it's very difficult for these patients to make that drive. So Ave Maria, even, and Immokalee, or anybody Lehigh out here trying to drive into Naples or Fort Myers, and you plan, you get your ride, you have somebody with you because a lot of times you need a driver, and then you get into town, which takes about an hour, and then you get set up, you wait in the waiting room for however long, you get your blood drawn, then you get to the back where the nurse can assess you and it's like, oh, we can't do this because something as simple as an eye exam. I get it.
Yes.
It's horrible if you think about what happens to patients, and that's definitely always a frustrating part on my end, especially as a provider. And that could have been that situation, or where people were left in the lobby and forgotten for an hour because of a
Yeah.
check in process mistake. And then they come to us hotter than heck, upset because they waited, but we had no idea in the back end. But those kind of things hurt me as a provider because I could really empathize with the patients because we're all patients. I wouldn't want to wait an hour, or I wouldn't want to drive if my doctor's office is not prepared. And then that creates a trust issue as well too, right? You're like, well, if you can't get this little baby step right, how do I know you're giving me the right treatment? So
Yes.
it's
Yes.
important. Nurse navigators are so important in oncology, and they need to keep them around for that purpose. We need more of those.
I
So
know.
with
I did
that,
a little bit.
I don't doubt that you did that too. With that in mind, with like providers and communication and everything we've talked about, um, what do you think makes a provider easy to work with? Like, what kind of traits or what kind of actions make them easy to work with?
Provider who is, open to the communication, the flow of communication with the nurses,
Mm-hmm.
and is approachable.
This is
And
important.
it's very important. The we and it's a society thing. We are putting the doctors on pedestals, and but they can be reached,
Yes.
or they should be brought down from their pedestal so we can have open communication with them.
Right, because ultimately it's
And
about the
some are,
patient. Sorry, I mean to interrupt you, but yeah, I agree.
and that's what it is. In the end, I am. in the infusion room to treat your patient. So communicate with me. Allow me to come to you freely and have an open mind. Don't shut me down when I would like to communicate with you. And some doctors, I have to say that I've been, pretty lucky. Hopefully it's not going to
Knock on
crash
wood.
down.
Knock on wood.
But I have been pretty lucky with being able to communicate with the providers.
That's good.
And in the end, they are human beings. I'm a human being. I am here to treat your patient. You know it. You know, I'm not there to be doing anything wrong or to be trying to waste your time.
Right.
So welcome my input. Listen to what I have to say and communicate. Talk to me.
I love it. I think it's perfect. Did you find a way that was better for communication than others?
I I love to run back
I
to
know.
their office and just I don't care. I'm gonna do, 15,000 steps a day, but
Yeah.
I rather unfortunately it's not very welcome, by all providers. But I want to talk to you face to face, and I feel that it's easier at times to talk to you face to face for 2 seconds than having to type on the teams, through the text back and forth to try to explain the status.
Yeah.
S bar is so easy when you speak. It's
Yes. Or
so
just
difficult when you have to
use
type
it.
everything.
Yes. I can't tell you how many times, and I don't know if it's a newer generation of nurses or what, but and not even just nurses, I mean, anybody, they've lost the idea of SBAR. Just give me the situation, give me the background, give me your assessment, and then most importantly, give me your recommendation. Because, like you said, you are there, you're next to their bed, you're already thinking of a plan, especially if you're a good nurse, you're already thinking ahead of what might be the options. And you just say, hey, I recommend, what do you think about this, this, and this? And then the provider, doctor could just be like, no, I don't think so. It should go this way. Or, yeah, that's a great idea. And then you feel amazing because you're like, holy crap, I knew the answer. This is excellent. And it's good. Oh, I
Yes.
love it. Yeah, the teams always got me. Because, if you're with a patient and you're trying to focus on the patient in the room, then you're trying to go to teams and you're like, where's my attention supposed to be? Or especially if it's an email that wasn't getting answered till the end of the day because of all the patients and teams and everything. So I always appreciate right in front of my face more than anything.
And I'm old school. I want to speak to people.
How dare
I
you? Makes no sense. We just need a text, right?
yeah, it's like, what?
Next time you should just FaceTime me. I'm like, oh, face to face with technology. All right. Well, I love everything you
Yes.
talked about. The last question I have for you is, what advice would you give to new oncology nurses?
Wow.
Don't say don't do it.
Treat your patient like if it was a loved one always. Oncology, not oncology. It's always been my go-to.
Yeah.
Treat the patient how you would want to be treated or how you would want your mother, your father, your child to be treated.
I think that is a great way to leave it because that's just a great
Yeah.
way to live life. And whether you're medical field or even outside, just, dealing with
Oh,
people,
definitely.
except driving in Naples, then it's just war.
Oh,
Okay.
we'll leave that.
That's a different world. Perfect. Did you have anything else you want to say, Christelle? You did so amazing and so wonderful.
No, thank you. Thank you for having me. I really enjoyed, this talk.
Yeah, it's great. And thank you for coming on because, I have plenty of students all the time that come to me and they're trying to figure out their pathway, which way they want to go. And sometimes oncology just seems scary because they don't hone in on it a lot. There's a lot of biology behind it, there's a lot of genetics behind it, there's a lot of different pathways to take with it, and they just get scared because I think it feels like almost so scientific, and not a lot of people are always geared that way, or just scared of the medications and the names of the medicines, and the fact that people are getting cancer sometimes can just be scary for people. But I think it's one of the most rewarding career fields I've ever been in. I've done a lot of different fields as nurse and nurse practitioner, but I think oncology patients are the most grateful, the most almost the most easiest to work with. And it's just rewarding when you be able to help somebody, whether that means we can treat them and cure them, or if that means we can help them to find peace, especially in the end, and just realize what's important for them, and then they can choose the right path for them. So I really like it.
Yeah,
I love it. Okay. Well, thank you to
love
everybody
it.
who watched our video today, Thriving Beyond the Stethoscope. I'm Natalie Tyler, and I look forward to our next discussion. Thanks, Christelle.
You're welcome.